Today, we aren't just wading into the shallow end of endocrinology. We are executing a full-scale emergency protocol for one of the most high-stakes metabolic crises you will ever encounter: diabetic ketoacidosis, or DKA.
DKA is a true biochemical storm. It's not a condition you see every day, but when it hits, the clock is absolutely ticking. The mortality rates, even in modern settings, are still quoted around 2 to 5%. This demands precision, rapid action, and a really deep understanding of the cascade of events happening inside the patient.
And you're here because you need that high-yield guide, a shortcut to competence. Our mission is to extract the definitive step-by-step emergency management protocol, moving you rapidly from diagnosis through the critical 3 pillars of treatment right through to a successful resolution. We're decoding the chaos.
Right, and to start, we have to be absolutely sure of the diagnosis. DKA is not just high blood sugar. It's defined by a necessary triad of biochemical markers. If you're missing one, you're likely dealing with something else entirely.
Okay, let's nail down that foundation. Component 1 is hyperglycemia. We're looking for a blood glucose level greater than 11 millimole, or if you're working in U.S. units, that's over 250 milli-GDL.
Correct. The second component is acidosis. This means the body's chemistry is, well, it's dangerously acidic. We measure this with a venous pH of 7.3 or less, and you often see a bicarbonate level of 15 millimole or lower along with it.
And crucially, the third part of the triad, ketosis. You have to have ketones. So you'd quantify this with blood ketones at 3 millimole or greater, or maybe your analysis showing 3+ ketones.
Exactly. It's the combination of all three: hyperglycemia, acidosis, and ketosis. That combination dictates this specific emergency protocol.
Okay, so let's zoom in on the why. Why does the system just completely break down like this?
The genesis of DKA is pretty straightforward at its core. It's an absolute, or sometimes just a relative, lack of insulin coupled with a surge of counter-regulatory hormones, think glucagon, cortisol, the stress hormones.
And that biological double whammy launches 2 destructive pathways at the same time, and you have to treat both. Pathway 1 is the glucose cascade. No insulin means cells can't take up glucose, leading to that profound hyperglycemia we just mentioned.
Right, and that high concentration of sugar in the blood acts as a powerful osmotic agent. It literally drags water out of the cells and into the urine, which starts this massive osmotic diuresis. You get relentless polyuria, and the result is just a catastrophic loss of fluid and electrolytes.
Catastrophic is the right word. We're not talking about minor dehydration here. Patients in DKA are routinely found to have a total fluid deficit of, 6 to 8 liters?
6 to 8 liters is typical. It's like losing 2 gallons of liquid from your system. It is massive. And that really underscores why immediate volume replacement is the non-negotiable first priority.
Okay, so that's pathway 1. What's the second pathway?
Pathway 2 is the acidic cascade. When the body can't use glucose for fuel, it switches to breaking down fat lipolysis. This generates free fatty acids, which the liver then oxidizes into ketones, specifically beta-hydroxybutyrate. And its accumulation is what drives the severe metabolic acidosis, which you'll see as that wide, elevated anion gap.
So this is the real danger, right? It's not the sugar that kills them. It's the acid load that messes with cardiac and respiratory function.
Precisely. And clinically, you can often spot this process. Following the standard ABCDE approach, you'll see all the signs of profound dehydration: thirst, dry mucous membranes, tachycardia, and potentially outright hypotension.
Now the respiratory system starts fighting back against that acid, which is where you get that famous or infamous Kussmaul respiration, that deep, rapid breathing.
Yes, it's designed to blow off CO2 and try to compensate for the acidosis. Sometimes you even catch that faint, sweet, fruity odor of acetone on their breath.
And I've heard GI symptoms are huge too.
They are nausea, vomiting, and frequently severe nonspecific abdominal pain that can be very alarming. It can even mimic a surgical acute abdomen. You have to be wary of mistaking DKA for a primary GI problem.
And the severity of the DKA that matters for where the patient goes. What are the red flags that mean we need to call for critical care?
Severe DKA is defined by a few key indicators: a pH below 7.1, blood ketones greater than 6 millimole, any altered mental status, say a GCS less than 12, or the presence of frank shock, meaning a systolic blood pressure below 90 millimole Hg. Those patients need to be in the highest level of care. immediately.
Okay, we have the diagnosis, we have the mechanism, but DKA rarely happens out of the blue. We have to find the trigger, because if you fix the DKA but miss the cause, they'll just crash again. These are the eye triggers, right?
Yes. And the reigning champion, the most common precipitating factor, is infection. We see this all the time with urinary tract infections, pneumonia, skin infections.
There's a great clinical pearl here, isn't there? About fever and DKA.
There is. If your patient has DKA, fever itself is not typical. The inflammatory response to the acidosis often leads to hypothermia or just a normal temperature. So if you find a fever, it is a very strong signal. It points to an underlying active infection you absolutely must track down.
That's a critical distinction. So beyond infection, what else are we looking for?
We look at insufficient insulin noncompliance, maybe a failed insulin pump. We also need to consider catastrophic events like infarction, a silent MI, or a stroke, which trigger that massive stress hormone release.
Then there's just general intercurrent illness, like trauma or extreme stress. And we can't forget that for up to 25% of cases, DKA is the initial diagnosis of type 1 diabetes, especially in younger patients.
Right. And finally, we often see intoxication, particularly alcohol abuse and being impregnated. Pregnancy itself is a potent trigger, and managing DKA during gestation is extremely difficult.
So the moment you suspect DKA, the diagnostic engine in the emergency department has to fire instantly. What are the essential tests we need before we even think about starting treatment?
Bedside tests are immediate: blood glucose, urinalysis for ketones, and a 12-lead ECG. The ECG is non-negotiable, not just to look for ischemia from a potential MI trigger, but critically to evaluate the patient's potassium status. Both hyper and hypokalemia leave clear, life-threatening signatures on the cardiac rhythm.
And the labs.
You need a blood gas. Venous is fine to confirm the pH and bicarbonate, but the most crucial core labs are the urea and electrolytes. We are laser-focused on potassium.
And the pace of potassium change during treatment is just insane. How often do we need to monitor it?
This is a major differentiator between good and bad DKA management. You must check serum electrolytes, especially potassium, every 2 hours. Every 2 hours until the patient is stable and the insulin infusion is titrated down. That frequency is absolutely non-negotiable. The minute you start insulin, potassium shifts rapidly back into cells, threatening the heart.
Okay, we've diagnosed, investigated, confirmed. Now for the battle plan. The treatment hierarchy is paramount. The 3 pillars of management.
And this order is the key to safety. It's fluids, potassium, then insulin. Failure to follow this order is one of the most common mistakes, leading to really bad outcomes.
Let's start with pillar 1, fluids. We are talking aggressive volume restoration. This is the first action taken.
Absolutely. Restore circulatory volume, reverse the shock state. The aggressiveness depends on how they present. If the patient is in frank hypovolemic shock SBP less than or equal to 90, you give a large, rapid bolus, 1 to 2 liters of 0.9% normal saline right away until that systolic is above 90.
But if they're normotensive, the plan changes a bit, but it's still aggressive at the start, right?
It is. You start with 1 liter of 0.9% saline over the first hour. Then you slow down to replace that remaining 6 to 8 liter deficit more gradually, typically 500 milliliters an hour for the next 4 hours, then reducing to 250 to 500 an hour after that.
That sounds like a lot of fluid in a short time. How do we balance that? I mean, what about fragile patients?
That's the critical decision point. You have to use extreme caution in patients who are elderly, pregnant, or have pre-existing heart or kidney failure. They are highly susceptible to volume overload. If you start seeing signs of pulmonary congestion, you have to slow the rate. But for the vast majority of young, otherwise healthy DKA patients, fluids must be aggressive.
Once fluids are running, we hit pillar 2. This is the critical checkpoint, potassium. I think it's fair to call potassium management the single biggest safety net in DKA treatment.
It is the absolute gatekeeper. You're trying to prevent iatrogenic, life-threatening cardiac dysrhythmias. You see, while DKA presents with total body potassium depletion from all the diuresis, the serum level can look normal or even high. That's because the acidosis drives potassium out of the cells.
And when you give insulin, it's like a bulldozer driving that potassium right back into the cells. So if the patient's already low, you just created a fatal hypokalemia.
Exactly, which leads to the hard stop rule. Never initiate the insulin infusion if the serum potassium is less than 3.3 millimol.
So if K+ is low, what's the intervention?
You hold the insulin completely. You immediately start high-rate potassium replacement, 20 to 40 millitube per hour, and you only proceed to pillar 3, the insulin, once that level is safely above 3.3. You stabilize the heart first.
And if K+ is in that optimal, safe range, say 3.3 to 5.2?
Then you proceed with insulin, but you actively add potassium replacement into the IV fluids, usually 20 to 30 milliQ of K plus per liter. You're aiming to maintain levels in that sweet spot, 4 to 5 millimol, because you know the insulin is going to drop it.
And if a patient presents with a high potassium, over 5.2.
You can proceed with the insulin, but you hold the replacement initially. But, and this is key, you must recheck it frequently. Every 2 hours is essential, because as the acidosis and dehydration resolve, that potassium will rapidly shift, and you will need to start replacing it aggressively.
Okay, checkpoint cleared. We move to pillar 3. Insulin. We're starting a continuous IV infusion of regular insulin. What's the target rate?
The standard protocol is 0.1 units per kilogram per hour, using a regular insulin like Actrepid. And again, this only starts if K plus is greater than 3.3. The overriding goal here is not just to reduce sugar, but to reach the concentration required to forcefully suppress ketogenesis.
A practical note for a busy ED.
Yeah.
If you know the dedicated IV infusion pump setup is going to be delayed, say more than 30 minutes, is there a quick fix? Can you get the ball rolling?
Yes, there is a clinical pearl here. You can give 10 units of regular insulin stat, either IM or IV push. It's a temporary measure, but it immediately starts the process of blocking lipolysis and suppressing ketone production while you finalize the continuous infusion.
And we have to constantly assess if it's working. What are the key metrics to troubleshoot that infusion rate?
We check 2 things every hour. Is the glucose decreasing by at least 2.8 millimol an hour? Or is the bicarbonate increasing by at least 3 millimol an hour? If neither of those targets is being met, you have to increase the insulin infusion rate by 1 unit an hour until you see that metabolic movement.
This brings us to the critical pivot. The treatment is working, the glucose is dropping. When glucose hits 14 millimol, or sometimes 11.1, we have to make a big change.
This is perhaps the most important decision point after the potassium check. If you keep the patient on pure saline and insulin, they will become severely hypoglycemic while still being very acidotic. We haven't resolved the ketosis yet.
Right. The primary goal of insulin is closing the anion gap, not just normalizing the glucose. So we pivot the fluids to provide a constant source of sugar.
Exactly. You change the IV fluids to dextrose 5% or 10% combined with 0.45% ACL. You infuse this at a rate of 125 to 250 milliliters an hour. The new target is to actively maintain the patient's blood glucose in a therapeutic range, say, between 8.3 and 11.1 millimol until DKA is completely resolved. You're using the dextrose to allow you to keep the insulin running to clear the ketones without bottoming out their sugar.
Okay, let's touch on ancillary treatments. We mentioned DKA being a hypercoagulable state.
Yes. Due to the extreme dehydration and hyperglycemia, the thrombosis risk is elevated. Prophylactic low molecular weight heparin should be administered to prevent clots.
And the controversial one, bicarbonate. It seems logical to treat acidosis with a base, but protocols generally advise against it. Why is that?
Bicarbonate can actually worsen acidosis inside the cells and cause rebound hypocapnia. It also dramatically increases the risk of cerebral edema, especially in children, so it's generally not recommended. We only consider it if the patient's arterial pH is catastrophically low, below 6.9. And even then, the goal is just to raise the pH above 7.0, not to normalize it. Let the body fix the acid with insulin and fluids.
And finally, we have to flag the special case we're seeing more and more, euglycemic DKA.
This is a really challenging diagnosis because the classic hyperglycemia symptom is missing. The patient has the required ketosis and acidosis, but their glucose is less than 13.9 millimol.
And what causes that?
Yeah. The causes are generally specific conditions that limit glucose release but still induce insulin deficiency. Things like SGLT2 inhibitor, use of common diabetes drug pregnancy, or severe alcohol use and malnutrition. And crucially, the management path is the same. Fluids, potassium, then insulin. You just start that dextrose pivot much, much earlier.
Resolution and disposition. All DKA patients are going to the hospital, no exceptions. And when do we finally declare mission accomplished?
Critical care is mandatory for severe cases or high-risk patients. We declare resolution when the glucose is less than 11.1 millimol A&D, the patient meets 2 of 3 criteria. Serum bicarbonate greater than or equal to 15, venous pH greater than 7.3, or most importantly, the anion gap is less than or equal to 12. That closing of the anion gap confirms the metabolic chaos is truly over.
And the final switch from that intensive IV protocol back to normal insulin.
You only switch from IV to subcutaneous insulin once they've met those resolution criteria, they're stable, and they're able to eat. And here's the last procedural rule. The IV insulin infusion should only be stopped 2 hours after the first subcutaneous dose is given. That overlap prevents any gap in effective insulin coverage.
We've covered the entire scope of this crisis. To summarize the 3 core principles you need to internalize. 1. Fluids are the immediate, non-negotiable priority. Restore volume first.
2. Potassium is the safety net. Check it and correct it before starting insulin to prevent those life-threatening cardiac events.
And 3. Continue insulin until ketosis resolves. Don't be fooled by normalized glucose. The real goal is closing that anion gap, which is why the dextrose pivot is an absolute necessity.
It's a complex dance of sugar, salt, and acid, but if you follow the pillars, you stabilize the patient.
As a final provocative thought for you to take away, especially with the rise of medications like SGLT2 inhibitors that often cause that euglycemic DKA we discussed, how much does the existence of this variant force clinicians to stop relying on the high glucose level as a quick diagnostic crutch? It puts the full weight of the initial assessment, the abdominal pain, the Kussmaul breathing, and the necessity of immediate blood ketone testing right at the forefront. It demands critical thinking, beyond just the bedside glucose meter.
A critical shift in thinking for a critical condition. Mastering DKA is about understanding the metabolic forces at play, not just following a static checklist.